Hello, this is Dr. Nolan. I hope you're having a good day. This next set of discussions is going to be on hematological disorders. This first set of lectures, I'm going to basically cover topics related more to red blood disorders, and then we'll talk in the next hour after this about coagulation disorders. So let's get into it first. Basically, the first thing we'll talk about is how red blood cells, also known as erythrocytes, they're extensively produced in the bone marrow of the adult human. Uh, in a baby, they may actually be not only formed in the bone marrow, but may also be involved in things like in the sternum, and it's also in the other organ systems in the body. But mostly, when we're talking about erythrocyte production in the adult, we're looking at the bone marrow. Uh, the actual red blood cells are actually quite numerous, and when you think about it, they account for a total of 1/4 of the total number of cells in a human being. So that shows you how really critical they are in the actual transport of essential oxygen and CO2 removal from the cells. These are very highly specialized cells that are produced in the bone marrow, and they actually have their nucleus removed and much of their organelles being removed prior to being delivered into the bloodstream. It doesn't mean that the red blood cells are just little, just carriers of hemoglobin, but they actually do have some metabolic system still in place to make their function capable, functionally capable. But their functionality usually lasts for a limited time because it doesn't have DNA to reprocess itself. So really, red blood cells are really limited in lifespan for about 100 to 120 days. Um, the the few organelles that it does have are responsible for basically maintaining certain forms of energy requirements that are largely supplied by glucose metabolism, which is readily available in the bloodstream. So it kind of makes sense that a carrier like this would be using glucose as its main source of energy. It's basically uses metabolism to maintain hemoglobin in a soluble reduced state. It also helps provide adequate levels of 2,3-DPG, and it generates ATP basically to support also membrane functionality. And because as we show you in a few minutes, red blood cells, their actual structure is very critical for their function. Uh, the other thing that the red blood cell is really known for, and most people think about red blood cells, is repositories of hemoglobin. Okay, and hemoglobin is a very complex protein that has within it a porphyrin moiety, which we call heme, and that heme has iron in it that allows it to combine with oxygen, and the actual protein around it, the hemoglobin configuration containing 2 alpha and 2 beta chains, can alter its configuration to accept and help remove oxygen from that heme moiety. Remember that the normal lifespan for red blood cells is limited to around 100 to 120 cc's, so they're having to be constantly being produced. Now, red blood cells are also stored in large amounts inside the spleen. So approximately you have 1 unit of red blood cells just sitting in your spleen under normal conditions. So when you have a traumatic injury, you may actually get autotransfusion from the spleen by it squeezing and pushing out this readily available extra amount of red blood cells. Once you deplete red blood cells, it takes a while for the bone marrow to replete it, and it takes a lot of energy to produce these kind of cells, and that's a detrimental side of it, is that it takes time to replace patients that are becoming anemic. And if you begin to exceed the eventual production rate, then the person will develop anemia over time. This is a really nice photograph showing you how red blood cells are produced in the bone marrow, how they have extensive mitochondria and certain kinds of organelles, and they have a nucleus. But as you can see, as the bone marrow process goes through, the nucleus is actually expelled, and the mature erythrocyte still has high levels of mitochondria, but by the time they start being delivered into the bloodstream, the erythrocyte basically loses its mitochondria, and the ribosomes and then the plasma reticulum and other forms of subcellular components by autophagy which means that it auto-digests it. And what you end up having is this kind of discoid shape that has sort of like a indentation in the middle on both sides. Now, you have to really understand that this is actually a weird structure, and it makes you wonder, like, why would it be the purpose of having such an odd structure? Why not just make it round? And the answer has to do with this kind of shape allows it to travel through readily through microvasculature and capillaries. It increases the surface area by being able to slide through. Red blood cells are actually pretty pliable and they can actually give. And when you lose that pliability or you make it into a spheroid shape, you basically begin to lose this ability to travel through microcapillaries effectively. Now, the actual shape that is maintained actually requires a lot of work, and it requires proteins and special kind of subcellular structures that are within the cell to maintain that shape. So what I've done for you here is imagine that this portion of the red blood cell has been cut open and then peeled, and you can see the phospholipid bilayer here, and within it you see proteins being embedded inside the actual lipid bilayer. These proteins' functions are anchoring points for more specialized proteins that act like chains that hold this shape in place. This all requires energy and calcium utilization as well. And if you lose this ability to have energy source to keep these bindings in place, then the actual shape of the red blood cell begins to distort, and as a consequence, you get more of breakdown of these red blood cells as it travels through the capillaries. These are very important proteins, which we'll talk about later, and there's actually disease processes where these proteins are lacking or there's not enough attachment points, and as a consequence, the actual shape of the red blood cell alters. Again, the other very important component of the erythrocyte is inside the cytoplasm, and basically your red blood cells are huge carriers for this molecule called hemoglobin. And within the normal hemoglobin, there's usually 4 heme components, which are porphyrins, which we've talked about before in metabolic disorders. But that component is where the binding takes place of oxygen to the iron component. But still, the carrier of this hemoiety is hemoglobin. And this hemoglobin protein complex gives us the ability for the actual binding and unbinding of oxygen in different states. So remember that there's 2 alphas and there's 2 betas, and each one has a very specific property because you're looking at proteins as these beta chains and alpha chains are made of. You can have alterations in gene structure where you get mistakes made, and we'll talk about these later on as they affect the actual hemoglobin quality, and either will not be able to carry oxygen adequately or actually carry it too well and won't let it release. Ultimately, erythrocytes are the cellular component of blood, and when you spin it out, plasma is about 55 to 60%. So a normal hematocrit for an individual adult male is usually around 45 milliequivalents. Sorry, 45%. That's what usually would say hematocrit's 45. That's what they're trying to indicate to you, that the actual red cell component to the total fluid is around 45%. All right, so there's different forms of erythrocyte disorders that you have. You may have abnormal concentrations, like you don't have enough of red blood cells, such as anemias, or you have too many, like in polycythemias. You may also have abnormal structures in hemoglobin, which we'll talk about a little later on. And then you get clinical manifestations of all these arrangements, such as inadequate in oxygen carrying capacity, and actually begins to impair the adequacy of oxygen tissue delivery. Now let's talk about anemia first, which is a lack of a numeric deficiency of erythrocytes. Unfortunately, there's really no single laboratory value that defines anemia because anemia could be dilutional, which is not really a true anemia, or it could be due to actual loss of erythrocytes. So hematocrit may actually be unchanged despite acute blood loss, which is another thing that would indicate still that you have anemia, but because you're losing the same amount of plasma as you're losing red blood cells, you won't pick it up. This is very often seen in trauma patients where the patient's not received any blood products and has lost a lot of volume, and you're actually the patient's hypotensive and significantly hypovolemic. But when you actually draw the lab test, it basically the person looks like they have an adequate number of hemoglobin as well as an adequate number of hematocrit. Well, once you start giving these people fluids and crystalloids usually, then the person becomes symptomatically anemic. Well, they're already anemic already, but they become laboratorily visible that they're anemic as their red blood cell numbers begin to fall, and their hematocrit falls as well. Usually our main way of describing somebody who's anemic, let's say is not hypovolemic and is not losing blood, is usually a hemoglobin that they're less than 11.5 grams per deciliter, or a hematocrit less than 36 for a woman. As for a male, males tend to have more red blood cells simply because they're not menstruating. As a consequence, they have a hemoglobin count around 12.5 grams per deciliter, with hematocrits that are higher than the 40% range. Uh, Ultimately, anemia impacts the actual delivery of oxygen, which is oxygen carrying capacity. Remember when we talk about the oxygen dissociation curve, which we'll show you in the next slide, that the actual concentrating ability is what accounts for total delivery. The actual dissolved amount is very, very low and is not survivable if you don't have enough of the hemoglobin molecules readily available. Uh, Compensation is accomplished by usually by a rightward shift of the hemoglobin dissociation curve, which actually helps facilitate the release of the oxygen from the hemoglobin to tissue. You can also see a compensation by an increase in cardiac output, which is also a reflection of a decrease in blood viscosity. And also the partial compensation over time is that the kidney increases its production of erythropoietin, which subsequently stimulates erythroid precursors in the bone marrow to basically produce additional red blood cells. One of the things that you will see with patients that develop anemia is they develop increasing levels of fatigue, and they have very limited exercise tolerance due to the inability of the cardiac output to basically further increase and maintain adequate levels of tissue oxygenation. The chronic forms of chronic anemia are things like iron deficiency anemia, patients with chronic diseases, patients with have thalassemias, or patients that have had traumatic injuries with acute blood loss. The oxyhemoglobin dissociation curve here, one of the things that is missing on this side, which is I try to reiterate on you, is that this is the oxygen carrying capacity, the total amount. The oxygen dissociation curve shifts to the left and right. Remember, in the situation where you get a rightward shift, where you actually get higher binding affinity, would be things like decreasing levels of 2,3-DPG. Patients that would have higher oxygen holding capacity at that point. The other thing that would account for that would be colder temperatures and alterations in pH, such as a more alkalotic state. On the other hand, you can see a shift to the right in patients with have decreasing pHs. Elevations in 2,3-DPG and increasing temperatures will make the oxygen lose its affinity to the hemoglobin and come off more readily. So those are the things that you always have to remember and expect that on your test. Anesthetic considerations for anemia, that is there a minimal acceptable hemoglobin concentration? Well, that's really controversial. It depends really on a lot of the pathological problems that the patient is having at the time. So really you have multiple guidelines, but these truly are just guidelines, and you still have to use your clinical acumen to decide if you need to transfuse somebody or not. Okay. Basically, things that will try to avoid decreasing oxygen delivery and minimizing drug-induced decreases in cardiac output is part of the treatment plan. You want to minimize your respiratory alkalosis from iatrogenic hyperventilation, which then will cause a leftward shift in the oxygen hemoglobin dissociation curve and basically decrease the amount of delivery of oxygen to tissue. You want to minimize decreasing the body temperature, also shifts the oxygen dissociation curve to the left. which holds the oxygen more, so making somebody cold actually decreases delivery to tissues as well. Uh, Decreased tissue oxygen requirements may accompany depressant effects of anesthetic agents in hypothermia, which may offset some of the decreases in tissue oxygen delivery needs with anemia to unpredictable degrees. So sometimes people will tell you, if you make the person cold, the person will tolerate it better. Yes, to a certain degree that's true, but you gotta also remember that if you make them too cold, then the oxygen just doesn't come off the hemoglobin molecule, and literally the tissue begins to starve for oxygen. Um, it's really very difficult to appreciate the amount of actual delivery going on in the patient, and still it's something that we don't really have a real good monitor for it at this time. If you look at the next set of disorders of red blood cell structure, is production of red blood cells is still, remember, under control of the bone marrow, and the bone marrow is actually in the control of humoral effects as well as cellular growth factors. One of the things that is very important is erythropoietin, which is produced by the kidney. Kidneys basically have oxygen sensors in them that detect minute changes in the amount of oxygen available to the tissue. Anytime that the oxygen levels begin to fall or chronically depressed, you have a subsequent increase in total erythropoietin production, which then increases the bone marrow production of red blood cells. The downside is in chronic renal failure, the erythropoietin production can be completely lapse or stop being produced, and as a consequence, a person becomes significantly anemic over time. Um, the unique structure of the adult red blood cell provides the maximum flexibility. The cell travels through this microvasculature, and it's really important for that to be maintained. If you start losing the ability for this structure to be maintained intact, like these essential proteins that I showed you in the previous pictures, then you get things like what's called hereditary spherocytosis. This is a DNA defective disease process where you saw autosomal dominant in more than 60% of these patients. The other, about 20%, is due to sporadic mutations, and another 20% is due to recessive mutations. It's actually the most commonly inherited hemolytic anemia in Europe and the United States with a frequency of 1 in 5,000. The principal defect is a deficiency in the membrane skeletal proteins, usually spectrin and acrin. This leads to an abnormal osmotic fragility and a shortened circulatory half-life. And as a consequence, the spleen begins to sequester these spherocytes, which shows they form spheres more round, and the person will get splenomegaly as a consequence. Patients usually develop symptoms of anemia, such as easy fatigability. Hemolytic crisis may be precipitated by viral or bacterial infections. These patients will develop jaundice as the hemoglobin gets distributed in its free form into the bloodstream, and then gets processed by the liver, which then breaks it down, hemoglobin into heme components, and breaks it down to bilirubin, which then has to be removed by the GI tract system. So jaundice may be prevalent if extensive hemolysis is taking place. It may cause an overabundance of bilirubin to get through the liver, causing gallstone, what's called pigmented gallstones, in a high proportion of these patients with hereditary spherocytosis. So this is a nice picture showing you what the properties of spectrin and acrin are. It's basically to hold the shape in place. And if you lose these deficiency, you will basically develop a sphere. Okay, and you get these kind of round shapes. You see it loses the discoid shape like you have. This leads to splenic trapping, erythrostasis, leads to unfortunate decreases in acid in the bloodstream because of lactic acidosis, inadequate perfusion. It may also increase macrophage contact and leads to an increased level of hemolysis. You may also get further loss of membranes and formation of more microspherocytes. Ultimately, what you're looking at is a disturbance in the actual spectrin and acrin, which are these components here. These are the actual protein structures that are becoming weakened in this disease process, and as a consequence, you get the alteration in your shape of the cell. There's another one that's also related to this kind of disease process called hereditary ellipsoitis. elliptocytosis. You can see these pictures here. It's a more of elliptical shape, almost like a bacterial shape to the red blood cell. This is an autosomal dominant disorder, and it has hetero and homozygous. And the heterozygous is only rarely experienced hemolysis, for the homozygous, which account for about 10% of this disease process, or compound heterozygous defects, may demonstrate greater degrees of hemolysis and accordingly much more severe anemia. Um, the actual inheritance for this is mostly related to malaria, as these patients are found in higher frequencies in areas that are endemic to malaria. So this the heterozygous property may actually improve the person's survival, very much like sickle cell anemia does for those individuals, sickle cell trait. So sometimes altering your red cell fragility makes it more difficult for things that are parasites that attack the red blood cell, like malaria, to actually survive long enough to go to full maturity. So breakdown of those products, red cells at an earlier stage, basically breaks down the process of that person getting the risk of getting malaria. We think that hereditary elliptocytosis is basically an abnormality of one of the membrane proteins, in case, again, spectrin, but one of the different ones in this case is glycophorin that makes up the erythrocyte much less pliable. You have also funnier ones that look like this, which are called acanthocytosis. Acanthocytosis is a congenital lack of lipoprotein B, which is an A beta lipoproteinemia. It's infrequently seen with severe cirrhosis and pancreatitis as it begins to attack the liver and the pancreas. It results basically from cholesterol sphygmomyelin accumulation in the outer membrane of the erythrocyte, making it much more rigid, and it also makes it develop these kind of little spicules that are on the red blood cell. The secretion gives the membrane a spiculated appearance that signals the splenic macrophages and the reticular endothelial system to cull from the circulation, producing hemolysis. You also have more rare disorders called like paroxysmal nocturnal hemoglobinuria. So these are individuals that you'll see hemoglobinuria at night. It's a clonal disorder that arises from hemopoietic cells anywhere from the 2nd to 8th decade of life, so you usually don't see it in children. Abnormalities are in the reductions in the membrane protein known as what's called glycosphatidyl-glycan. The increased risk for development of DVTs due to activation and coagulation by these dysregulated complement activation. And it's a chronic disorder with hemolytic anemia. And then, unfortunately, the mean life expectancy after diagnosis is about 8 to 10 years. So it is becoming, it is one of those diseases that is lethal. What you see in these individuals is that that their urine actually changes color at night. And it becomes red like this, that's indicating hemolysis. And then during the daytime, the urine goes back to a more normal shape. We think that it's a complement-activated disease process where the cells become basically responsive to it's an autoimmune disease process. As a consequence, the complement activation, it becomes activated and breaks the red blood cells, causing hemolysis to take place. What's interesting about this is they have a new drug called eculizumab, which binds and inhibits the actual C5 from binding onto these cells, and as a consequence stops the hemolysis. The other thing that you'll see is in disorders affecting red cell membrane, the stability of the red cell membrane and the solubility of the intracellular hemoglobin depends on 4 glucose-supported metabolic pathways. So the actual hemoglobin itself can be altered by disorders of these of glucose-supported metabolic pathways. These pathways include what's called the Embden-Meyerhof pathway. This is a pathway that's taking glucose in a non-oxidative or anaerobic pathway to generate ATP necessary for membrane function and to maintain the cell shape and pliability. Defects in this anaerobic glycolysis are associated with increased cell rigidity, decreased survival, which then produces hemolytic anemia. The normal pathway for glucose, which is readily available in the bloodstream, is conversion into glucose 6-phosphate, which then eventually goes into formation of what's called glycerolaldehyde 3-phosphate, and eventually at that point it decides to go into your tricyclic acid pathway, or in this case it can go into an anaerobic pathway like this to produce lactate. Okay, um, and if you have the next process, what's called the phosphogluconate pathway, this couples oxidative metabolisms with NADH and glutathione reductase. It counteracts environmental oxidants and prevents globulin denaturation, which means that your hemoglobin doesn't denature. Two enzymes are really critical, and it can become diseases if you have lack of these, including glucose 6-phosphate dehydrogenase and glutathione reductase. If you don't have adequate levels of these two enzymes, it leads to denatured hemoglobin, which then precipitates on the inner surface of the red blood cell and then results in membrane damage and hemolysis. So what you see in this individual's is the lack of this enzyme eventually leads to accumulation of many of the byproducts, and also you get a decrease in production of energy metabolites that produce ATP, which also affects the actual memory stability. You also have, so let's look at the individual enzymes. Let's look at the first one, which is glucose 6-phosphate dehydrogenase deficiency. It's actually one of the most prevalent diseases causing mutations. You have hundreds of millions of people worldwide, specifically seen in the Mediterranean, Southeast Asia, and Chinese territories. It's encoded on the X chromosome, so it tends to be seen in males much more prevalently than females. The erythrocytes contain higher levels of glutathione reductase than any other cells in the body, and they act as critical antioxidants to protect the red blood cells from oxygen toxicity. So lacking glutathione reductase and glucose 6-phosphate dehydrogenase is going to cause some significant problems with your hemoglobin stability. Clinical manifestations of these are basically leads to chronic hemolytic anemia or episodes of acute episodic hemolytic anemia, and sometimes you have no apparent risk for hemolysis, but they still hemolyze. It could be from a viral infection that's just not being picked up. Acute insults that actually precipitate or or aggravate pre-existing hemolytic anemias, such as this, or infections. Okay, drugs that may cause increased levels of antioxidants to be produced. In the Mediterranean, if you ingest high levels of fava bean, these people become very symptomatic and develop very severe forms of hemolytic anemia. And then methylene blue is actually very much of a concern if you are having somebody with methylene methemoglobin toxicity and you give methylene blue to somebody who's glucose 6-phosphate dehydrogenase deficiency, you may actually cause a worsening problem. Okay, so this is actually may become life-threatening anemia that's due to hemolysis that you give to somebody methylene blue, these individuals. As for the other enzyme deficiencies, pyruvate kinase, it's the most common erythrocyte enzyme defect causing congenital hemolytic anemia. It tends to be an autosomal recessive mutation. It's found worldwide, and again, the same thing in regions of European extraction as well as some areas of China. It leads to accumulation of 2,3-DPG in the red cells, which causes the shift of the oxygen hemoglobin dissociation curve towards the to the left, to the right, to facilitate oxygen release from the hemoglobin to the peripheral tissues. So these people will have very high levels of oxygen being released into the tissue, but on the return trip to the lungs, you'll notice that the actual value of hemoglobin on bound oxygen is actually very low, and if they don't have sufficient time to uptake enough oxygen in the lung, it may develop some degrees of hypoxemia or desaturation. Sorry. One of the treatments for this is splenectomy, but sometimes splenectomy does not totally prevent hemolysis, but does decrease the rate of red blood cell destruction. severely affected individuals, because you do have extensive hemolysis in this, is that you develop jaundice. They also develop pigmented gallstones and unfortunately develop splenomegaly. The next pathway that's also important for glucose metabolism is hemoglobin reductase pathway. This uses a molecule called pyridine nucleotide reduced nicotine NAD generated from anaerobic glycolysis to basically maintain the heme iron in its ferrous state. It leads to an inherited mutation that results in an inability to counteract oxidation of hemoglobin to methemoglobin, and the ferric form of hemoglobin, then it will not transport oxygen as a consequence. The type 1 reduced NAD diaphrase deficiency accumulates in small amounts in methemoglobin in circulating red blood cells. And then type 2 patients have much more severe forms of cyanosis and will also have mental retardation due to this lack of oxygen to the brain cells. The next pathway is the Luberin-Rappaport pathway. It's responsible for the production of also 2,3-DPG. The balance of formation versus metabolism, 2,3-DPG is very pH sensitive. If you think about it, alkalosis favors synthetase activity. In acidosis, the phosphatase activity is much more favored. The T3-DPG response is also influenced by the supply of phosphate to the cell. And severe phosphate depletion in patients with diabetic ketoacidosis or nutritional deficiency can actually result in a reduced 2,3-DPG production response. All right, let's go on to the next component of the red cell, which is the hemoglobin molecule. You can actually have the adequate numbers of red blood cells, but if the hemoglobin itself, that's contained in the cytoplasm, is not in good quality, then it can't really uptake oxygen and deliver it properly. The actual amount of, if you look at the actual dry weight of hemoglobin in comparison to cell mass, it actually comprises 90% of total mass in the red blood cell, which is pretty impressive. I mean, it's a large amount of material. Each heme group itself is capable of binding to an oxygen molecule. Remember, there's 4 heme groups for every hemoglobin. The hemoglobin molecule has extensive ability to bind to many different forms of oxygen. There's also, unfortunately, because it is a protein, it has functionality as protein. It can reconfigure and change its shape, and it, as a consequence, can affect the ability for the oxygen to bind and dissociate from the heme component. But the downside to it is that the complexity of it means that it has much more increased frequency of actually having some kind of transcription error or translation error, and the actual hemoglobin molecule may actually become dysfunctional. So there are actually many defects that are substitutions of single amino acids in either the alpha and beta globin chains. And there's actually been at least over 100 of these been described so far. Some may actually interfere with the molecular movement, restricting the molecule from either low or high affinity state. Others either change the valency of heme iron from pyrrhous to ferric to reduce the solubility of the hemoglobin molecule. And there's disease states like hemoglobin S, which is sickle cell disease, is an example of a single amino acid substitution that results in reduced solubility, typically causing precipitation of abnormal hemoglobin. So if you begin to precipitate the molecule of hemoglobin, it begins to bind to the actual surface of the cell, and it causes problems with the proper structure, and actually alters the structure, and we'll show you how it sickles the cell in sickle cell disease. Eventually, disorders in hemoglobin, because it affects the ability for it to stay in solution, will begin to cause hemolysis by altering the hemoglobin. The molecule clumps and precipitates. This precipitation then damages the cell wall integrity, which leads to hemolysis, and as a consequence may lead to anemia. Let's talk about the first one. Let's talk about sickle cell S hemoglobin can come either the heterozygous and homozygous fashion. If you have the homozygous fashion, it's much more severe, which we call sickle cell disease. It's usually a disorder caused by a single amino acid substitution of valine for glutamic acid in the beta globulin subunit. So it's not affecting the alpha subunit, but it's affecting the beta subunit. It's in the deoxygenated state that hemoglobin S undergoes conformational change, exposing what's called a hydrophobic region of the molecule. In extreme states of deoxygenation, this hydrophobic area will tend to aggregate with other forms and results in distortion of the erythrocyte membrane and oxidative damage to the membrane and impaired deformability and shortened lifespan for that red cell. What you see in this effect, basically this is a normal cell, this is a sickle cell. You see how they begin to clump together and basically prevent blood from going to peripheral tissue. And as a consequence, this person begins to suffer signs of lactic acidosis with severe pain and even organ infarcts, strokes, heart attacks, lung infarcts, splenic infarcts, bone marrow infarcts. It's pretty bad news. This stuff is very, very painful. In sickle cell anemia, this is the actual homozygous form of hemoglobin S disease. It presents, unfortunately, very early in life with severe hemolytic anemia and vaso-occlusive disease. It involves the bone marrow. These people suffer from severe episodic painful crisis, especially at the bone and joint pain that may or may not be associated with other concurrent illnesses. The spleen usually develops significant enlargement, so you get splenomegaly. You get recurrent splenic infarctions, eventually culminating in loss of splenic function, usually by the first decade of life. The kidney itself, the renal medulla, is the prime target. With loss of concentrating ability, an early feature of disease is progression of chronic renal failure, usually in the third or fourth decade of life, which ends up usually being the leading cause of death in these individuals. Pulmonary-wise, it does cause significant morbidity and mortality with progressive lung damage due to persistent inflammatory reactions punctuated by severe acute chest pain and pneumonia-like complications associated with new pulmonary infiltrates involving at least one or complete lung segments and at least one of the following: chest pain, fever, higher than 38.5, tachypnea, wheezing, or cough. As for central nervous system, they can get strokes, may also infarct and cause necrosis of certain portions of the brain, including increased incidence of development of abscesses in the brain as well. Sickle cell anemia, you can see the normal red blood cell here compared to a sickle cell. Usually sickle cells are not evident until certain levels of oxygen are become low enough. So sometimes you'll see this in the normal slides, and as long as the oxygen levels are adequate, you don't see the sickling. The sickle cell trait does not increase the actual perioperative morbidity or mortality for us. So if you have somebody who tells you they have sickle cell trait, you don't have to really worry about it. The reason that most likely people have sickle cell trait in the African continent and the Mediterranean population is simply because these people tend to survive malaria better. So there is a basically environmental toxin pressure that has been applied to that population, which is why they've had this appear in their genetic profiling. As for sickle cell anemia, this is a much more concern to us, and it depends on the incidence of perioperative complications will depend on the surgical procedure. The risk that you have to look at is look at age. As you increase in age, the actual amount of multi-organ system disease is actually much higher. The actual frequency of hospitalizations tells you the degree of sickle cell crisis that individual is suffering. The actual frequency of transfusions for episodes of crisis is also important, as it would indicate to you the more severity of disease. If you have organ damage, such as low baseline oxygen saturation, will indicate to you kidney function disease, such as elevated creatinine, cardiac dysfunction, including history of MIs, development of arrhythmias, including bundle branch blocks. You can also have central nervous system events, such as strokes, and concurrent infections because of low perfusion, and the immune system becomes suppressed as a consequence. So these people have a significantly increased risk for developing infections. The anesthetic risk intrinsic to certain types of diseases, certain minus procedures such as inguinal hernia repair or extremity surgery are considered low risk, but things that are intermediate risk are things like intra-abdominal operations such as gallbladder. One of the surprising things that people get surprised about is under normal circumstances when we think about a hip replacement or a knee replacement, those are considered not such a high risk, but for sickle cell patients, it is a high risk procedure. The reason being is, especially for knee replacements in these individuals, is that they usually have to put tourniquets up on these individuals, and as a consequence, the anaerobic area below the tourniquet will sickle the cells, and you get a sickling crisis in that individual. So some of these can actually be from the actual tourniquet. The goals for preoperative transfusion management is that under low-risk procedures, rarely do you need to give preoperative transfusions. But if you have moderate to high-risk operations, you need only to have the preoperative anemia corrected to a target hematocrit around 30. That's usually the guideline that most people use. So please remember that. That would be a test question. Indicate that hematocrits are greater than 30. Usually need to be at least at 30 before you start these operations. The actual choice of anesthetic technique does not really significantly affect the risk of complications stemming from sickle cell disease. But one of the things that you want to avoid is dehydration, to avoid acidosis, as this will cause the sickling crisis to occur more rapidly, as well as hypothermia. The things that are not completely contraindicated is occlusive orthopedic tourniquets, because bleeding is just as much of a problem as well. But just understand that you may induce a sickling crisis by inducing a prolonged tourniquet time. These children, even adults at that point, have a very difficult time with pain control because they usually are narcotic dependent, and as a consequence develop severe resistance to narcotics. One of the things that you may also develop typically 2 or 3 days after the postoperative period is what's called acute chest syndrome. This is actually a very, very bad prognosis, as it usually will develop into full ARDS in these individuals. You need to really keep a close eye and an aggressive focus on oxygenation, provide adequate analgesia, and then frequent blood transfusions to correct the anemia and to improve oxygenation in these individuals. What you see in things like this, where you see the acute chest syndrome, is that you'll get regional hypoxemia. This causes a cellular dehydration and increased adhesion to the endothelium. And as a consequence, you get microvascular occlusion and tissue infarction and hemolysis. This hemolysis induces the anemia, which decreases the hemoglobin and nitric oxide binding sites. This leads to local pulmonary nitric oxide accumulation with loss of HPV. So you get a lot of BQ mismatch and shunt effects. The decreased nitric oxide bound hemoglobin leads to a decrease in nitrous oxide delivery. Regional hypoxemia gets worse. The shunt causes desaturated hemoglobin, which also decreases hemoglobin's oxygen delivery, and makes the regional hypoxemia even worse. So this tends to basically be a process that keeps getting worse and worse and worse.